طيب, Assalamu alaikum. So now we're going to talk about the ultrasound of the shoulder. I've tried to make it as simple as possible, so for the basic and intermediate level. So definitely we need to understand our basic anatomy of the shoulder and then how to do the scanning technique. So our objectives today, we're going to talk about the shoulder anatomy. Just going to head to the sono anatomy, which is a very important things that we need to see in our ultrasound. Pathology of the shoulder and intra-articular joint injection briefly. So we all have shoulder pain, and in our clinic we might see a lot of patients with shoulder pain. What we expect that we might see either tendon tear or tendon rotator cuff tendinopathy. There might be calcification, there might be an osteoarthritis in the joint. So how to identify that other than the history and physical examination? So just want to ask, how many of you had scanned ultrasound shoulder before? Did ultrasound scan, or just 2, 3? Okay. So just a quick review about our anatomy. So this is the bone of the shoulder. We can see from the front and the anterior part and the posterior part. As we can see here, this is one of our landmark, the acromion and the clavicle here, and the coracoid, and then the joint that we are going to scan. And we can see here the greater tuberosity and lesser tuberosity. And in between is the bicipital groove. Here where we see the bicipital tendon. And from the posterior side, we can see the spine of the scapula. And definitely we need to know our landmark of the tendons. So we have 4 tendons for the rotator cuff. From the top, we can see the supraspinatus tendon. We can review the supraspinatus from the top, anterior and the posterior part slightly, as well as the posterior part is the infraspinatus tendon, and the subscapularis tendon we can see it from the anterior part of the shoulder. With the external rotation of the shoulder, we will see that. The teres minor is not that very important as the other tendons, because it's one of the least tendons that might affect for the any tendon tear. So this picture is very important just to understand our anatomy when we scan the shoulder. From the lateral part, which we can see here, the supraspinatus tendon, it comes in the above and attached in this part. So anteriorly is the anterior part is the subscapularis tendon, superior part is the supraspinatus tendon, and the posterior part is the infraspinatus tendon. We can see here the insertion of the supraspinatus tendon and the infraspinatus tendon in the upper part of the greater tuberosity, and you can see here the overlap of the supraspinatus and infraspinatus tendon. So we cannot differentiate when we scan the supraspinatus and infraspinatus tendon with the ultrasound scan. The bicipital groove, we need to scan that as well. And when we go to the anterior part of the subscapularis tendon. Here we need to know that the biceps tendon, we have the long head and the short head. What we always scan is the long head of the biceps tendon, which is located between the greater tuberosity and lesser tuberosity. And on top of that is the deltoid muscle. So the deltoid muscle cover all these the tendons, and we can see in between this deltoid muscle and the supraspinatus tendon the bursa. It's not only about the joints, the bone, and the tendons, and it's a lot of complicated structure. We'll see a lot of ligaments, but one of the ligaments that we can scan is the coracoacromial ligament between the coracoid and the acromion. So what's the essential to scan for the ultrasound? So definitely we need to have a good machine with the linear probe of 7.5 to 16 megahertz. We need the patient to be in sitting position, 90 degrees of the elbow, slightly internally rotated of the elbow, and the dynamic examination. So one of the important thing here in the shoulder compared to others, that we need to scan the patient while he's moving, like extension, abduction, internal and external rotation of the shoulder, to view all the rotator cuff tendons. So what to examine? We will scan the biceps tendon in longitudinal and transverse. We will scan the subscapularis tendon, coracoacromial ligament, supraspinatus in longitudinal and transverse, and also the subacromial subdeltoid bursa. We will look at the acromioclavicular joint, and the infraspinatus tendon, and lastly the glenohumeral joint. So this is the neutral position for the patient. We ask all the patients to sitting position, 90-degree flexion of the elbow, slightly internal rotation. So that's we're going to scan firstly the anterior part of the biceps tendon. So this is what we are looking at. So as you can see here, we put this one in transverse position for the probe, and we locate the greater tuberosity and lesser tuberosity, and in between is the long head of the biceps tendon. Sometimes when we might see an hypoechoic means dark the color. That means we call it anisotropy. Anisotropy means the probe is not perpendicular to the tendon. So we need just to tilt our probe until we see the tendon clearly hyperechoic structure filled with the hypoechoic. So it's not to be only full of the hypoechoic. So because sometimes there might be a rupture of the biceps tendon, you need to tilt the probe to make sure that you see the hyperechoic structure. But if it's only hypoechoic, that means there might be a rupture of the tendon. So when we do scanning, we need to do proximal and distal to the biceps tendon. We can see the in between the biceps tendon located in between the supraspinatus and the subscapularis tendon. So that's from the proximal, and then we go distally down until we reach to the pectoralis major tendon. So we have to assess the full picture of the biceps tendon anteriorly to locate if there is any sign of tenosynovitis around the tendon. Can you video please? Video. So we can see here the full length of the normal scanning from the proximal. So we can see here the biceps tendon in between the groove. We have to scan down until we reach the pectoralis major tendon. So we have to do full assessment of the biceps tendon. Once we've done from the transverse position, we have to do longitudinal position of the probe to be longitudinal to the biceps tendon. This is what we see here. So as I mentioned before, the deltoid muscle is covering all the rotator cuff tendons, and we can see the hyperechoic and hypoechoic fibrillar bundles of the biceps tendon very clear. This is the proximal part, and this is the distal part. But sometimes, definitely the biceps tendon proximal is more superficial, but distal is more deeper, going down to touch to the bone. So we will see proximal is very clear, and when we go distally, there will be more hypoechoic. So we need to tilt our probe and press down. We call it heel to toe, until we try to make our best to bring the biceps tendon totally parallel to the probe. Why? Because if we didn't do that, we might confuse this one with if there is any blackish color in here, because of the anisotropy, we might confuse it with the tenosynovitis. So we try our best to make sure that's very clear and there is no tendon tear. So that's about the biceps tendon, and then we go, because we are in the anterior part, we do the subscapularis tendon. So the subscapularis is deeper part. We have to expose that by asking the patient to do external rotation. So the patient is in the same position. We just ask to do external rotation. As we can see here, this is the long head of the biceps tendon, greater tuberosity, lesser tuberosity, and this is subscapularis tendon, which goes deeper next to the coracoid. So this is a neutral position. When we ask patient to do external rotation, we will move the subscapularis tendon to be more exposed anteriorly and to be parallel to the probe. So this is anisotropy, as I mentioned before, because it's not parallel to the probe. But when we expose the subscapularis tendon external rotation, we can see here the probe is totally parallel to the tendon, and you can see the fine and the nice here fibrillar fibers of the hyperechoic bundles for the tendon. So this is a video you can see here. We ask the patient to do external rotation to expose totally. Internal rotation, you will see the dark color. So we don't confuse ourselves, this one with the fluid. You just need to ask the patient to do fully external rotation. There is a pitfall of the subscapularis tendon. As you can see here, there is small blackish. This is what we call it musculotendinous junction. So we don't confuse this with the tear. So this is normal in the subscapularis tendon. If you see the blackish color, Think about it, it's a pitfall. So there is a junction between the muscle and the tendon, because the muscle looks darker and the tendon whiter. So this is the junction between. So you don't confuse this with the tendon tear, because the tendon tear looks as dark as this one. So we've done the longitudinal scan of the subsquares, and then we do the transverse scan. Because the tendon comes from this side to that side, that's what we call it longitudinal scan, and then we move it 90 degrees to be in transverse scan. We all have to scan longitudinal and transverse section for the tendon. So it looks also almost similar. We can see the head of the humerus here, the bone. We can see the subscapularis after external rotation, and we will see the deltoid muscle, as I mentioned, it's above it. Sometimes we might see some collection of fluid, so that might be a collection of fluid inside the bursa. So this is a good spot to do an injection of the subscapularis bursa, and this is the coracoid. And also this is a pitfall, or this is a normal appearance. As I mentioned, that's the musculosyndinous junction, and also you might see multiple of hyperechoic junction, because subscapularis has a lot of bundles, so that's what we call the tendon fascicles. So don't confuse yourself if you see this hyperechoic with a calcification or anything else. Okay, so subscapularis done, biceps tendon done, and then we just go above to look for the coracoacromial ligament. So we can locate the acromion and coracoid, and you can do that by hand, and just slide the probe in between. That's the video. You can see here this subscapularis, and you can see here you just move it, and this is the ligament between the coracoid and acromion. Actually, for myself, we rarely see any trauma in this ligament, but it's better to assess if the patient complains of any pain at this site. So we've done all of these three structures, and then we go to the supraspinatus tendon. Supraspinatus tendon needs a dynamic maneuver. We need to move the patient to do a modified cross position. So just ask the patient to put their palm backward. Why? Because we need to expose this is the patient in neutral position. We need to expose the supraspinatus tendon anteriorly. As you can see here, this is the biceps tendon groove. Next to it is the supraspinatus tendon. If it's a neutral position, it will be in the lateral side, but we need to expose it anteriorly. So this is why we ask the patient to do in this position. Some patients, they cannot move their shoulder, but we can ask them as much as they can. If they cannot do the modified one, they can just put their hands backward. So this is how it looks like. It's near to the acromion. This is one of our landmark. Once we see the acromion, so we know that we are next to the supraspinatus tendon. You can see here the head of the humerus, greater tuberosity where the supraspinatus attach, and definitely the deltoid above it. So when we look at the subacromial subdeltoid bursa, it will be above the supraspinatus tendon and just below the deltoid muscle. Here where it collects the fluid for the subacromial subdeltoid bursa, and where we locate for the injection. So this is what we call it longitudinal scan, as this position. The one part at the acromion, and the other part just distal to the acromion in oblique position, longitudinal to the supraspinatus tendon. Here is an anisotropy as well. So as I mentioned, anisotropy means hypoechoic because the probe is not parallel to the tendon. So as you can see here, this is how it looks normally. The fibers of the tendon, they are like curvy to the insertion. So definitely there will be a blackish color or high anisotropy in this part. So what we need to do, we need to try as much as we can to move our probe to make it as clear as possible. Why? Because we need to make sure that we are not confusing this one with any tendon tear. This is again the anisotropy, and also there is a myotendinous junction, the same as the subscapularis muscle. So if you see this shape just at the beginning of the supraspinatus, you think of the myotendinous junction. If you see this one, you need to make sure that your probe is parallel. Try to move the probe as much as you can to be parallel to the tendon to make sure it's not a tendon tear. We've done with the longitudinal, and then we do the transverse scan. It's just move it 90 degrees. We will see the same supraspinatus tendon, the head of the humerus, and the deltoid. And in this part where we look at the subacromial subdeltoid bursa, and definitely if there is any collection of fluid, you will see blackish color, blackish line, and it's very easy to locate for injection. And this is, it's, as I mentioned, the supraspinatus is just next to the biceps tendon, and in here the subscapularis tendon. This is collects all the tendons together, easy to memorize. Supraspinatus in the above, infraspinatus in the back. You can see the overlap, so we cannot identify which is which if we scan from the anterior part to assess for the supraspinatus. But when you go backward, that will definitely see the infraspinatus tendon. And in between the supraspinatus tendon and the subscapularis, there is a biceps tendon. So supraspinatus tendon, biceps tendon, subscapularis, and the infraspinatus will be in this part in the back. Once we've done of all these, and then we go to the back. So we ask the patient to do the modified cross position, and then we just ask the patient to put their hand to the other part of the shoulder. Why? We need to scan of the posterior part of the shoulder for the glenohumeral joint, as well as of the infraspinatus tendon. So this is what we look at. We just try to localize the infraspinatus tendon, the head of the humerus, and above it the deltoid, because the deltoid is a big muscle, it covers all the tendons. In here, if we go from the lateral part, we move the probe more towards the middle center of the body, medially, we will see the glenohumeral joint, and we can see the glenoid labrum, which is a little bit of hyperechoic. So our aim for the injection, if we want to inject for the glenohumeral joint, from the posterior part towards, not to hit the glenoid labrum, but just above it, because this is the capsule where you can inject for the joint injection, or you want to do any aspiration for the joint. So this is the posterior part. I think this is a video, if I'm not mistaken. Yeah. So you can see here when I ask the patient to do external and internal rotation, it's the movement. This is the glenoid labrum, and you can spot in this part for the injection. And that's the infraspinatus tendon, and that's the deltoid muscle. And then we can do the transverse. So we did the longitudinal part. The transverse part is just scan all over. For me, the longitudinal scan is enough, but we need to scan all the transverse section. The teres minor, as I mentioned, that is one of the least one that to have any injury I haven't seen before. And this is the infraspinatus tendon, just we can scan as a transverse section. So that's all about the tendons, anteriorly, biceps, subscapularis, supraspinatus above, and then the infraspinatus with the glenohumeral joint. But we don't forget the acromioclavicular joint. The AC joint, one of the most important points that we need to look at. A lot of patients, they complain of pain at this part. This part might be the supraspinatus tendon, might be the AC joint. By examination, you will define where exactly. But with using the ultrasound machine, definitely it will help to assess, is it really the supraspinatus or just the AC joint. So the acromioclavicular joint, you will see this looks like the edge, a hypoechoic area, and this is also a very good spot when you scan to do an intraarticular injection for the AC joint. You will see if there is any osteophytes, so that will let you know definitely that this patient has mainly acromioclavicular joint osteoarthritis. So I've done all about the normal, and then we'll go about the pathologies to see what's the difference in between these. One of that is the subacromial impingement. We all hear about that, but we don't know what is it exactly, how it happens. So basically, when the patient asks to do an external rotation, abduction of the shoulder, they will just catch that, and they cannot do an abduction because of a pain. So that might be because of the subacromial subdeltoid bursa that catch when the supraspinatus slides under the acromion. So this is when the patient in normal position, we can see the acromion and the greater tuberosity, and we can see here the supraspinatus tendon, and then we ask the patient to do an abduction. So we need to hold the probe and ask the patient abduction and adduction, and you will see the slide of the supraspinatus tendon in and out. If the patient says here there is the pain, you need to look carefully where the tendon catch and where the pain says no, this is painful. So you might see just a bulge, or there is a catch of the supraspinatus tendon just underneath the acromion. That's a video, so you can see here. Sorry, is it a video? Can you excuse me? Hello.
Video, please.
Video. No? Sorry, maybe didn't. So, it's okay, it's okay. It's okay. So, it's okay. So, you can see the coracoid and supraspinatus, and here, this should work actually, but I don't know why it's not working. But when you ask the patient to do an abduction, abduction, you will see there is a bulge coming out because of the impingement syndrome. This is supraspinatus tendon changes might be. So we can see this is a normal supraspinatus tendon, and here, as you can see here, there's a very thin layer of the supraspinatus tendon, and there is, this is because of the tendon atrophy. Or maybe there is a tendinopathy. So it's not, it should be a tendon tear. It might be just thickened of the supraspinatus tendon. So we're going to talk about now about the tendon tear, where we're more likely to see either tendon tear or supraspinatus tendinopathy. So we might have just partial thickness tear, or we might have full thickness tear, or this might progress to be complete or massive tendon tear. So to differentiate between these with pictures, we can see here, we can call it bursal side partial thickness tear, or articular side partial thickness tear. What's the difference? You can see here, this is the supraspinatus tendon. You can see here the tear is just next to the bursa and underneath the deltoid. On the other hand, it's the tendon tear is just close to the bone. What's the difference? Just to mention, what's it, like when you write your report, where exactly the tendon tear? Is it just the articular side or the bursal side? And is it complete or just partial tendon tear? And this is when if it's not next to the bursal, not next to the bone, it might be just intratendinous, just in the middle of the tendon. We call it intratendinous partial thickness tear. What if it's a complete? The complete, it involves from the bursal side down to the joint part, to the bone part, or you don't see anything of the tendon, which is totally complete, and you will just see hyperechoic color because of the fluid. And that's the complete thickness tear. You might see calcification using the ultrasound. So, an hyperechoic inside the tendon, you move in longitudinal and transverse, it will be clearly this is the calcification. Or there might be a subacromial subdeltoid bursitis. So this is, as you can see, this is deltoid muscle, this is supraspinatus tendon, and in between there is a hyperechoic layer, which collection of fluid, where and this is a very good spot to put the needle inside the bursa to aspirate or inject the steroid. One of the abnormalities is the long head of the biceps tendon. As you can see, the tenosynovitis. So it's very good when you want to inject a patient complains of anterior part pain. It might not be the supraspinatus, it might be just tenosynovitis of the biceps head. So in transverse and longitudinal, you can see here a hyperechoic layer surrounding the tendon in transverse and also in longitudinal. So it's very easy to locate that anteriorly to inject and aspirate the fluid. Or you might not see any tendon. When you do the tilting, you're trying to find if there is anything, you will find nothing of the tendon. This is a rupture of the biceps, long head of the biceps. Or when the patient moves their hand, the biceps might displace. You can see this is the biceps groove. It goes out, so you know that the pain is because of the displacement of the biceps tendon. From the posterior part, this is a normal. We can see head of the head of the humerus, infraspinatus, and the deltoid muscle. While there is any infusion, it's easy to locate that. From the posterior side, you can see the infusion of the glenohumeral joint, and also it's easy to inject from the posterior part. Okay, so how many of you have done the injection blindly? All of you almost. Okay. with ultrasound. Okay, good few numbers. Okay, with ultrasound. So have you seen those who inject with ultrasound? Is there any difference?
Yes.
Easier or what?
So when blind, you might just do it like either posterior approach or lateral approach.
Okay,
But with the ultrasound guided, you target the area that you see that it's opening.
that's perfect. Yeah, definitely. And some patients, they come to me with, they had a previous injection, and when I scanned them, they had a huge swelling. And I said, did your doctor aspire that? They said no, because the doctor doesn't know what's going on inside. So it's better to scan to see if there's any fusion, to aspirate that, and analysis or injection. So, and this study just quickly, it shows that like ultrasound guided injection, it's accurate up to 97%, but the blind, some says 32%, some says is 50%. So it depends. Like it's like a chance I could say, but it's better to be with ultrasound guided. So here, subacromial subdeltoid bursa, it's easy to locate, easy to inject. Glenohumeral joint aspiration, easy from the posterior side, and even if there is no any fluid, you can inject posteriorly. That's my reference, and thank you.